I would devote a large part of my speech to address two pressing issues for healthcare. One is the hospital capacity crunch, the other is healthcare costs. Then I will talk about the major transformation that we are bringing about in our healthcare system, which will further address these two concerns. Mr. Pritam Singh, Mr. Ang Wei Neng, Associate Professor James Lim, raised the issue of capacity and waiting times at polyclinics and hospitals. Post-COVID, indeed, this is the experience of many countries around the world. Waiting times have gone up all around the world. In Singapore, what is driving up hospital bed occupancy is the increased number of seniors with complex conditions. Post-COVID, and we saw a surge in the numbers. I reported to the House earlier that average stay in hospital went up from about 6 days to 7 days, pre and post-COVID. And that alone represents a 15% increase in patient load. And this is happening against the backdrop of a rapidly aging population, which compounds the problem and makes it a long-term challenge. Mr. Singh suggested that we provide dynamic waiting times of emergency departments or EDs across hospitals publicly in real time. It's possible, but we have been reluctant to do so, I think for a good reason. Ambulances today already have a process in place to ferry patients needing urgent care to the nearest appropriate hospital for priority treatment. However, at the EDs, 40% of cases are not life-threatening or urgent, but they ended up there anyway. So our worry is that giving dynamic information may perversely drive more non-urgent cases to hospitals and worsen the overall situation. I know it is very uncomfortable, very unsettling for a patient who is quite unwell to have to wait many hours for a bed. But please be assured that hospitals will triage patients quickly upon arrival and start treatment for urgent cases, even if the patient is waiting for a bed. Mr. Ang Wei Neng raised the issue of Changi General Hospital, which was also reported in a Straits Times article. Changi is an old structure. It only had 4 ambulance bays, so the queue built up quite fast. But actually, that's not the limiting factor. We can always triage in the ambulance. It's a small problem. What we need to watch out for are ICU occupancy, resuscitation occupancy. If those are full, we divert. Ambulance bays are full, we can handle. On surface, it looks bad, but actually, operationally, it's not a huge problem to overcome. Associate Professor James Lim suggested using more urgent care centers, or UCCs. UCCs have been useful and effective. We have also been using the GP First scheme, especially around Changi area, and that is also useful. And we will continue to deploy all possible methods to alleviate patient loads at the EDs. To tackle the challenge more fundamentally, we need to expand capacity and catch up the time lost due to COVID-19 pandemic. We opened about 640 new acute and community hospital beds since June last year. They make up the over 11,000 public hospital beds that we have today. That's the stock we have, 11,000. We intend to add another 4,000 beds by 2030. And we should see new capacity coming on stream every year from now to 2030. Start with this year and next, 2024, 2025, Woodlands Health will commission up to 700 beds. 2026, Sengkang General Hospital and Outram Community Hospital are expected to expand by about 350 beds by converting non-clinical areas into hospital wards. Then 2027, the elective care center at SGH is expected to open. That has 300 beds. 2028, 2029, the redeveloped Alexandra Hospital is expected to open progressively. Then 2029, 2030, the new Eastern General Hospital campus is expected to open progressively. Then we move into early 2030s. That is when we hope to see the completion of a new regional public hospital that we have started work on. We have just completed one in the north, Woodlands Health. We are building another one in the east. We are expanding SGH in the central region. So the next new public hospital should be in the west. We are planning to site it in Teng Nga Town, which is an emerging population center. It will best complement current hospitals in the west. The new hospital in Teng Nga will be run by the National University Health System Cluster. Mr. Ang Wei Nen nodding his head. Notwithstanding this plan to expand capacity, we should not be trapped in the mindset of building hospitals when thinking about capacity. There is potential to better anchor care outside of hospitals in the community. Not all patients require high acuity care and constant monitoring in a hospital throughout their treatment course. Many need convalescent care and rehabilitation with the assurance that medical help is readily available nearby. That is why we have built more community hospitals for subacute and rehab patients and transitional care facilities for patients who are waiting for longer-term care arrangements. With our efforts, the number of long-staying patients have come down. And these are patients defined as medically stable for discharge, but they have been staying in hospitals while waiting for longer-term care, and they have been staying for longer than 21 days. This is what we refer to as long-staying patients. 2 years ago, it was about 300 such patients at any one time in our hospital system. Now it is under 200 patients at any one time, and there is still room for improvement. To facilitate appropriate transfers from acute hospitals to community settings, we will also be making a few policy changes as follows. 1, more funding for community hospitals. Acute hospitals have experienced friction in transferring suitable patients to community hospitals. Why? For example, certain diagnostic services, such as CT and MRI scans, and certain more expensive drugs are not subsidized in community hospitals today. This is based on the consideration that these are recovering patients and they may not need these interventions. Unfortunately, this means operational delays in transferring patients to community hospitals. There are patients who are medically ready to be transferred, but they're just waiting for a follow-up scan. They should be transferred without delay and do the scan at the community hospitals. Others worry that after transfer, what is unexpectedly, I need a scan for some reason. Hence, they insist on staying in the acute hospital just in case. To remove this friction from the last quarter of this year, we will allow more diagnostic services like CT and MRI scans and relevant drugs to be subsidized at community hospitals. More broadly, we will also align the community hospital subsidy framework to the acute hospital subsidy framework. It used to be different. That way, patients receive the same subsidy rate, which is 50 to 80%, throughout their inpatient stay, regardless of settings. And with this enhancement, most community hospital patients will see smaller hospital bills. Second change is make mobile inpatient care at home, or MIC at home, a mainstream service. What is MIC at home? This is a pilot project where we set up virtual hospital beds at the homes of patients and have doctors and nurses visit them as if they are in a hospital. Dr. Tan Wu Ming, Mr. Pritam Singh, Ms. Ng Ling Ling, and Ms. Mariam Jafar have asked or talked about such a scheme. At the end of last year, more than 2,000 patients have benefited from this scheme. This translates to around 9,000 hospital bed days saved. Having done this for several months, we are convinced that the scheme works well for the patients and has great potential to relieve stress at hospitals. Hence, from April this year, MIC at home will become a mainstream model of care in our public healthcare institutions. So as a result, patients can be assured that they will not pay any more for MIC at home than they do for acute inpatient care in a public hospital. All our hospitals intend to price MIC at home similar to or lower than a normal hospital ward. Patients will be supported by Subsidies, MediShield Life, and MediSave, no different from a physical inpatient stay. In response to Associate Professor Jamie Lim's suggestion, I don't think we therefore need to give an incentive for transition to home care now. It will be better to develop MIC at home into a well-accepted mainstream mode for acute inpatient care. We will also further expand the capacity of MIC at home as a first step from 100 in 2023 to 300 in 2024, with the potential to scale up further. Third change is to encourage telehealth. 40% of attendances in the typical polyclinic are for chronic care management. Last year, we extended subsidies and allowed the use of MediSave for the use of telehealth for chronic care. By the second half of this year, we will also expand MediSave coverage to telehealth consults for preventive care, such as follow-up reviews after regular health screening. This represents another 10% of polyclinic attendances. With this change, telehealth is treated almost the same way as physical consultations in terms of financial support. The only difference is telehealth for common illnesses. That is, when patients experience symptoms like cough, cold, fever. Patients still cannot use MediSave for such consults for common illnesses. Also for a good reason. We are holding this back as many people have been using such teleconsults as an easy way to get MCs. So there will need to be greater discipline in issuing MCs before we consider this final move. Another key aspect to expanding capacity is to enhance manpower. Mr. Ang Wei Nen, Dr. Tan Wu Ming asked if we need to produce more doctors to meet demand. Yes, we have been and will continue to do so. In fact, intakes into our local medical schools have increased by about 30% over the past 10 years to about 500 now. If you consider each cohort is now slightly over 30,000, about half of them, 15,000 or so, 15 to 17,000 go to university, and out of that group, 500 are training to be doctors. Still more are training to be allied health professionals and nurses. So we are taking quite a lot of talent. We are also offering awards and grants to actively attract Singaporeans who graduated from overseas medical schools back into the local public healthcare system. Where do we stand? Where do Singapore stand in terms of our doctor to population ratio? Ours, in terms of practicing doctor, is about 2.6. Let's put that number into some perspective. Compared to developing countries, we are ahead. We are higher. Compared to developed economies in Asia, we are similar. In fact, similar to Japan, which is also 2.6, to Korea, to Hong Kong, to Taiwan, all around 2.6. And considering that Japan actually aged much earlier than us, and their population, about 30% now, is 65 and beyond, and they also have a ratio of 2.6. Then if you compare to developed Anglo-Saxon countries, UK, US, Canada, we are slightly behind, not very far behind, just slightly behind. It is really when we compare to European countries, continental European countries, Australia, that we are a notch behind. Why is that so? I think there are various reasons. Could be a legacy of the welfare state, could be the fact that European countries don't really have a tradition of planning for manpower. There are various reasons. We can explore further if further increases are needed, but we have to recognize that talent is in short supply across all sectors. And healthcare, we should attract our fair share, but not disproportionate share of talent. Beyond this fair share, countries can also end up chasing its own tail. Why is that so? For one, it is not a simple numbers game. the right mix of doctors is just as important as the sheer number of doctors. If somehow doctors get registered but don't practice, doesn't help. If doctors are practicing but they go into areas like aesthetics, it also doesn't help very much. In Singapore, graduates from medical schools are already finding it more competitive to get residency positions to be trained as specialists, because there's not much of a shortage in many of these specialist areas. On the other hand, we are facing shortages in areas like family medicine, internal medicine, geriatric medicine, and rehab medicine. This is because as Singapore becomes a super-aged society, we have more patients with complex and multiple medical conditions, needing doctors with these more broad-based skill sets. Hence, MOH has been increasing the number of training positions in these specialist areas. We have also seen in many countries how supply of doctors creates its own demand. As more doctors compete for business, there will be a tendency to prescribe more tests, scans, medications, and procedures. Patients are not likely to say no because your health is at stake, and especially if healthcare is free or insurance covers all the costs. Hence, while Mr. Ang Wei Neng provided numbers to show that Singapore doctor to population ratio is lower than some OECD countries, this did not translate to poorer health outcomes, less accessibility or affordability in Singapore. For example, we know that US healthcare system is not the most accessible unless you have the right insurance. The UK, higher doctor to population ratio than us, have 8 million patients on their waiting list and is suffering from a chronic capacity crunch. Germany, also much higher than us in terms of the ratio, is facing a major challenge, meeting the healthcare needs of their seniors across their landes or their states. Conversely, Singapore, we are delivering quite good healthcare outcomes. A commonly accepted broad measure is the expected health span and lifespan of our people. In Singapore, a person is expected to live up to 74 years old in good health, one of the highest in the world, compared to 66 in the US, 70 in the UK, 71, 72 in Germany, France, Denmark, Netherlands, Australia, etc. Singapore achieved this by spending about 5% of our GDP on healthcare, compared to 10 to 13% in most developed countries, 17% in the US. In short, we have better outcomes with less spending and lower hospital beds and doctors to population ratios than many OECD countries, because it is not just a numbers game. The quality and the mix of doctors, the geographical spread of the country, how the whole system is run, the behavior of patients, all makes a big difference. We have a lot of room for improvement, but there is no reason to feel bad about ourselves or to envy others. We are in fact in a good place as we continue to learn from others and strive for improvements. Chair, let me now address the next concern, which is rising healthcare costs. Dr. Lim Wee Kiat, Ms. Mariam Jaafar, Ms. Ng Ling Ling asked, what is driving up healthcare costs? So in this section, I will talk about the likely reasons for rising healthcare costs, explain the realities of healthcare financing, and then what we are doing to try to moderate costs. A major factor for rising healthcare costs is that we are getting older, and as we get older, we are more likely to fall seriously ill. Over the last 5 years, the number of Singaporean seniors increased by almost 20%, from 560,000 to 690,000 now. We are on the verge of becoming a super-aged society. These are not macro numbers. It directly affects individuals and family. So when in a family, one member grows older and falls seriously ill, the entire family feels the burden of healthcare costs and also caregiving burden. Second reason, advancement in medical technology. Technological advancement, you can make a car or a smartphone cheaper and better. But in healthcare, it is often not the case. New treatments may work better, but always cost more. For example, advancement in orthopedic surgeries have made knee replacements much easier to do. In my constituencies, I met many seniors who have gone through knee replacements. Sometimes they've gone through both. And when I meet them, I've gone through one, we end up comparing our scars, our battle scars. In the past, people with degenerating blood vessels in their eyes due to old age, they will lose their central vision. Now the condition can be treated and controlled through repeated intravitreal injections. These advancements allow a person who cannot walk to walk again, allow a person who would have been blind to see again. The value to the patients is priceless. The cost to the patients have also gone up. Third, healthcare cost inflation. Even for the same treatment, not talking about medical advancement, same treatment, the cost has gone up. Inflation all around the world has gone up in recent years, and that has also affected healthcare costs. A key component of healthcare delivery costs is manpower. In Singapore, manpower is more than half of the cost to run the healthcare system. We all agree we need to compensate our healthcare workers fairly and competitively. As healthcare demands have gone up in many countries, the competition for medical manpower is now international and has become more intense. And this pushed up manpower costs and therefore healthcare costs. Finally, insurance. Insurance gives us peace of mind. But when the coverage becomes too generous, down to the last dollar, we start to see excessive prescriptions and tests and even unnecessary treatments. This is the classic buffet syndrome, which has driven up claims. Already paid for, might as well overeat. And therefore, it driven up claims, and therefore, it has driven up insurance premiums. Yet, it is frustrating to see insurance companies continue to offer unsustainable terms. Presumably, they are competing for market share. So how do we address rising healthcare costs? We need to first recognize two truisms in healthcare financing. Two truisms. The first truism is that ultimately, the people always pay. Let me explain with a personal example. When my wife and I moved to Switzerland for a year for me to do my master's program, that was 1999, we had to make a social security payment. I can't remember the name, but it's not cheap. A few thousand Swiss francs for two of us. It was compulsory. If we don't pay, we can't live in Switzerland. Then we got pregnant. My wife found a good gynecologist. Each time we visited her, we can just go in and go out, don't have to pay anything. Was it really free? Not really. We paid for it already through the rather expensive social security fee. In Britain, the National Health Service, or NHS, operates by the principle of free healthcare at the point of delivery. No UK government has ever touched that principle. It continues to be free at the point of delivery. But is it really free? Not really. The British have to pay high taxes to finance the NHS. And because there's no cost at the point of healthcare delivery, the waiting times at the NHS are very long. I talked about 8 million people waiting. So British patients are also paying with their time and their patience. So there are different ways to pay for healthcare: by taxes, by compulsory social security payments, through insurance premiums, or personal savings, or your personal time. Ultimately, the people always pay one way or another. That's truism number one. This leads to the second truism, which is how we pay affects how much we pay. If a government uses taxes to make healthcare free at the point of delivery, then it will likely lead to the buffet syndrome that I just mentioned. There will be overconsumption, wastage, high-cost inflation. If a government leaves the people to buy their own health insurance, people will tend to be very careful, which can moderate healthcare expenditure. But If someone did not buy insurance and is uninsured, they will be underserved. That is why in Singapore, we weave together a more robust way to pay for healthcare. It comprises subsidy funded by taxation, MediSave, which is your own personal savings, MediShield Life, which is a national insurance scheme, and MediFund, which is the final social safety net, what we term S plus 3Ms. S plus 3Ms ensures universality because it provides all Singaporeans access to quality healthcare. It is also a targeted system, focusing assistance on those who need it the most. So to illustrate, subsidies of up to 80% are extended to C-class wards in public hospitals, but not A-class wards, not private hospitals. MediShield Life covers a significant part of the remaining bill after subsidy, but we ensure some co-payment by patients, mostly through MediSave, so that there is less of a buffet syndrome. MediFund comes in for the lowest income who cannot afford the co-payment. And this is the key reason why we can achieve good health outcomes with national healthcare spending of 5% GDP, compared to jurisdictions with blanket assistance schemes. With these two truisms in mind, what can we do, and what are we doing about rising healthcare costs? First, let me start with the S of S plus 3M. Subsidies will have a big role to play. When I first joined the government, 2015, and entered this house, I was acting Minister for Education. MOE's budget was the second largest amongst ministries, at about $12 billion, only behind MINDEF's. MOH's was a distant third, just over $9 billion. Today, 9 years later, I become Minister for Health. MOH's budget has far surpassed MOE's to almost $19 billion, and not very far behind MINDEF's. MOH's budget is tax-funded. It is channeled to fund many aspects of the healthcare system, build new healthcare infrastructure, operate hospitals, polyclinics, and nursing homes, procure medicines and equipment, develop new IT systems, hiring doctors, nurses, and all our medical personnel. MOH's budget, tax-funded, constitutes healthcare subsidies, which have been rising significantly over the years. Then, the second M, MediShield Life, will also need to work harder. To this end, we will be conducting a comprehensive review of MediShield Life. MediShield Life, as I mentioned, is a national health insurance scheme. It covers everyone for life, even those with pre-existing illness. It is specifically designed for the great majority of subsidized patients who are encountering a major health episode. That last sentence needs some deciphering. It contains a couple of important phrases which I'll explain. I said covers great majority of subsidized patients because most Singaporeans seek subsidized care, and the great majority of them need financial assistance to foot their healthcare bills. Hence, for a C-class ward patient, he will find that after subsidy, MediShield Life claims should substantially pay for the rest of his hospital bill. For a patient that goes to a private hospital, he will find that MediShield Life covers only a modest part of his hospital bill. That's how MediShield Life is focused on the subsidized patient, especially those that uses C-class wards. Then a major health episode, because this upholds the spirit of insurance, which is to protect us against the rare occasions when we incur a big hospital bill because we fall seriously ill. With that context, let me report the state of MediShield Life today. It was designed such that 9 out of 10 subsidized bills are adequately covered. 9 out of 10. What remains are relatively small and expected co-payments which can be paid from MediSave. However, this 9 in 10 benchmark is being eroded because the size of hospital bills are getting larger and larger. Bill sizes have grown by 5% annually in public hospitals and by 7% annually in private hospitals over the last few years. As a result, the proportion of subsidized bills adequately covered by MediShield Life has come down to around 8 out of 10 and is expected to slip further. The practical impact. What is the practical impact? Subsidized patients are seeing hospital bills that are unexpectedly large. And after subsidy, after MediShield Life, there is still a substantial out-of-pocket component left. This is when higher healthcare costs really start to bite. MOH has therefore asked or tasked our MediShield Life Council, which is from various stakeholders, led by a private sector person. We have tasked the Council to comprehensively review the scheme, but we have given the Council some direction. First, enhance MediShield Life to give Singaporeans greater assurance against large bills. This means increasing how much a patient can claim from MediShield Life. This is what we call claim limits for both surgeries and hospital stays. We envisage a fairly significant increase in claim limits. For example, for an episode involving angioplasty, where a stent is placed into your heart to open up a blocked artery, plus, say, a few nights stay in ICU, the claim limits may need to double, times 2. This will reduce out-of-pocket costs significantly. Second, enhance other outpatient coverage. We also need to raise the claim limits for treatments, such as kidney dialysis, to reduce out-of-pocket expenses for patients. The Council will also explore extending coverage to more types of outpatient care. Some of the most costly outpatient treatments are for cancer. Ms. Sylvia Lim asked if we could improve financial literacy for patients to better plan against such a disease. There are resources available online, and we will raise the public's awareness to them. But I think the issue goes beyond financial literacy. It's actually more than that, more serious than that. We are facing an especially difficult challenge for cancer, as treatment costs were rising uncontrollably. So I'm not surprised at the survey results at all that you cited. Hence, we recently reviewed cancer drug financing and introduced changes that will allow us to negotiate for lower prices for cancer drugs. As a result, prices for approved cancer drugs has since dropped significantly, some by up to 60%. The impact is still playing out, and we will continue to monitor the situation. Third, the Council will consider expanding MediShield Life coverage to new groundbreaking treatments, specifically cell, tissue, and gene therapy products, CTGTPs. Medical science is advancing rapidly, and CTGTPs have the potential to revolutionize healthcare and deliver effective treatment of previously incurable diseases. Some describe these as the equivalent of a moonshot for healthcare. Essentially, the treatment involved, you extract blood from a patient, then with the blood, you teach and equip the cells in the blood to target and kill, say, cancer cells. Then you put the cells back into the patient's body to do its work. It is a one-time treatment. However, while the technology is promising and advancing fast, it is nascent and very expensive. It could cost anything from a few $100,000 to a few $1 million per treatment. We want to start including CTGTPs under MediShield Life. But we need to put in place safeguards to ensure that the financing of CTGTPs is sustainable. For instance, we will need to extend MediShield Life coverage only to treatments that are assessed to be safe, clinically effective, and cost-effective. In other words, if a treatment costs a few $1 million with a small hope of curing a small group of people, it is not cost-effective. This is a significant step to help all Singaporean patients, regardless of their income levels, have access to cost-effective, novel, state-of-the-art therapies. These proposed changes will better protect subsidized patients against major health episodes. MediShield life premiums, however, will inevitably go up. The last time we reviewed the scheme, premiums went up by 25% on average. But rest assured that we will do the necessary to ensure that as far as possible, premiums can be paid fully by MediSave. For example, we will consider enhancing premium subsidies or have MediSave top-ups for specific groups. We may have to use more MediSave for small hospital bills so that MediShield Life can better focus on big hospital bills, and that way we moderate premium increases. No one will lose MediShield Life coverage due to a genuine inability to afford the premiums. We will share more details when the Council completes its review in the second half of this year. Mr. Chair, while we address these immediate concerns, we should not lose sight of the longer-term strategic direction of healthcare. That is, continue to build health and not just treat illnesses. We have crystallized this strategy around Healthier SG. Ms. Ng Ling Ling, Mr. Yip Hon Wing, and Dr. Syed Harun asked for an update on Healthier SG. I'm very glad to say it has been progressing encouragingly. Let me report some data. Since the program was launched in July last year, we have invited 2.4 million Singapore residents aged 40 and above to participate. As of last month, 765,000 have enrolled with a family doctor of their choice. 60% are enrolled with GPs and the remaining with polyclinics. And this is a good split because a key thrust of Healthier SG is to empower our GPs to play a greater role in population health. Over half of the enrollees have started consulting their chosen doctors to develop a personal health plan, and they have been awarded $20 worth of health points. More than 124,000 enrollees have received their free vaccinations and health screenings. Over the past year, the number of participants in exercise sessions organized by the HPB has increased by 16%, from 133,000 to 154,000. For sessions organized by the PA, participation has gone up 12%, from about 400,000 to 450,000. For Sports SG session, it has increased by 20%, from 117,000 to 140,000. So we see a discernible increase in people becoming active, and individuals are also up and about on their own. The change, I think, is somewhat palpable, and this is the new active Singapore. Ms. Ng Ling Ling asked if we expect the prevalence rate of chronic illnesses to come down due to Healthier SG. That is certainly our aim. With a strong start to Healthier SG, we certainly hope this will happen, but it will take time. We have recently raised chronic drug subsidies for Healthier SG enrollees seeking care at their Healthier SG GP clinics. In the coming year, we plan to implement further improvements to the scheme. First, expand the range of health protocols. GPs are guided by Healthier SG protocols to ensure that residents enjoy consistent and quality care. There are 12 protocols so far, which include screening, vaccination, and management of common chronic illnesses. MOH will expand the range of protocols to cover more conditions, such as stable ischemic heart diseases and stable stroke. We will start to roll them out in early 2025, and as announced earlier, we are also starting to work on including aspects of mental health into the protocols. Second, we will improve the health plans. Currently, your enrolled doctor will co-develop a health plan with you as part of the preventive care consultation. It covers essential action items such as regular health screening and vaccinations. But on lifestyle, the advice is always quite generic, such as exercise more, eat better. In 2024, we will start to make the advice more specific. For example, it may recommend you to do aerobic exercise 3 times a week. You can then use Health 365 app to identify a suitable exercise activity near your home. And key features in Healthy 365 app will be made multilingual. Third, we will continue to roll out interventions for our seniors through the Age Well SG programs, which Second Minister Masagos have elaborated. Fourth, we will continue to fight against overconsumption of sugar and sodium. Our Nutri-Grade labeling of prepackaged drinks have been useful in changing consumer behavior. I will regularly and personally inspect the drinks in the members' room. Some of you saw me do it. I'm glad to report they are all graded A and B and passed the MOH ministerial inspection. There is one drink, however, 0 sugar salty lychee. So I texted my staff to say, what do we label this for sugar or for sodium? They told me just drink it. I also encountered students who asked for less sugar in their bubble tea, so it qualifies for Nutri-Grade B. As Minister for Education, I always tell students, don't be so grade conscious. But in this case, it's good to be grade conscious and go for A and B. We have recently extended Nutri-Grade to freshly made beverages. I met 2 key coffee shop associations recently and sought their support. The association leaders are fully on board. Together, they represent over half of the coffee shops in Singapore, and they intend to start serving siu dai, or less sugar, beverages by default. Means you order a kopi in future, they give you siu dai, even though you do not say it. If you want even less sugar, I recommend just drink kosong. Yeah. Sodium is the other culprit that can lead to heart diseases and strokes if over-consumed. It is found in salt, soya sauce, belacan, and other sauces. With much effort from HPB, over 60% of wholesalers of salt are now supplying low-sodium salt. About 30% of the catering industry are supporting our less salt, more taste movement. 20% of the food and beverage industry are also doing so. I recently saw an encouraging program on Channel 8. There are 2 lady hosts. They went on a 21-day challenge to take less salt and less sauces, soya sauce. At the end of that 21 days, their blood pressure measurements have moderated somewhat, but more importantly, their taste buds have become much more sensitive to salt. They could now taste ingredients better. They never knew when they taste something, there are undertones of garlic, ginger, spices. They used to just taste soya sauce and belacan. And they prefer to eat less salt now. It took 21 days to change a lifelong habit. Remember, because we eat every day, the effect of food accumulates through our lifetimes. And over our lifetimes, food can be medicine, food can also be poison. As a wise TCM doctor once told me, if you eat well, there is no need for medicine. If you don't eat well, medicine is of little use. Mr. Chair, Dr. Tan Wu Meng urged that healthcare needs to be delivered across time and space, which we agree. This is, in fact, a key aspect of the transformation we are striving for. Whereas sickness often needs to be treated in clinics and hospitals, health almost exclusively has to be built up in communities and in homes. MOH has been working on this transformation, and we have made a few strategic policy changes over the last couple of years. Patient data, it needs to flow across care delivery settings, from hospitals to clinics to senior care and rehab centers. This piece of work is almost done. What remains is a new law, which I hope to table in this House in the later part of this year. Regulation needs to move from being premises-centric to services-centric, so we don't regulate hospitals or clinics, but services delivered, regardless of settings. That is why we revamp our legislation to enact the new Healthcare Services Act, or HCSA. Financial support needs to be settings and premises neutral. But we cannot simply apply this based on first principles. It is bound to lead to abuse and unintended behavior. So instead, we progressively identify the situations and circumstances where premises neutrality should apply, and then make deliberate rule changes. We made a few changes last year on the mutual recognition of MediFund and extension of MediSafe support to manage chronic illnesses via telehealth. This year, I just announced further moves on community hospitals, MIC at home, and MediSafe support for telehealth. Most importantly, we need to be decisive and deliberate in making investments in preventive care and health of our population. We often hear calls for investment in hospital capacity, in our medical manpower. It is valid. But what is more important for the long term is capacity expansion in communities and society, in its ability to prevent sickness and build health. We are doing so via Healthier SG. And we are starting to see a change. More residents are coming forward to exercise, cycle, run, or brisk walk. People are watching their sugar intake. Sodium takes a while more. F&B players are switching to lower sodium salt. Miss Christine Locke, who sells nasi lemak, she was the first to do so at our Bukit Canberra Hawker Centre. She did so voluntarily because she had a loved one who suffered a heart attack. And she said, I want to take care of my customers. Film director Jack Neo started a brisk walking group for seniors, started during the pandemic. It's called Pa Pa Zao. In English, I think it means walking around for fun. I think so. Every week, his event is every week, and will attract almost 1,000 participants, young and old, from all over Singapore. If they descend on one of your communities, you will immediately notice 1,000 people gathering somewhere. For them, brisk walking has become a new habit, and they made new friends. Jack and his team, they even composed a song about Pa Pa Zao and incorporated messages of Healthier SG. They didn't consult me. So when I joined them 2 weeks ago, everyone sang the song. Everyone knew the song except me. Let me also share the story of Miss Cynthia Phua. Many members will know her. She was a former member of parliament. She agreed to let me share her story with you today. She enrolled into Healthier SG late last year with a GP clinic near her home. The GP noticed that she had not done a mammogram for 3 years, so repeatedly reminded her to do so. Eventually, she did late last year. That was when Cynthia found out that she might have breast cancer, and it was later confirmed through a biopsy. Fortunately, it was discovered early. She has since gone through an operation to remove the tumor, and no further tumors were discovered in her body. Cynthia is now resting and undergoing treatment. She's in good spirits. We wish her all the best. She wants me to tell everyone, please push for Healthier SG in your communities. You know how persistent Cynthia can be when she calls for action, because it can change lives and it can save lives. The UK Legatum Institute ranks healthcare systems in the world in a holistic manner. They do not just take into account of your doctor-to-population ratio, of your healthcare capacity, or what kind of state-of-the-art equipment you use, but they also evaluate population health and preventive care systems. They rank Singapore as having the best healthcare system in the world in 2023. This is a valuable vote of confidence in our system. It encourages us to improve and do better. It is said that there is an unbreakable iron triangle in healthcare. There are 3 aims in healthcare: affordability, quality, and accessibility. They are also trade-offs, such that improvement in one area always comes at the expenses of the other 2 areas. I have outlined how, by using MIC at home and right siting, we can increase capacity without necessarily building more hospital beds. In other words, improve accessibility without compromising quality of care. By weaving insurance and co-payment, we reduce out-of-pocket payment for patients while containing excessive demand for healthcare, hence improving affordability without undermining accessibility. And more importantly, by building better health through Healthier SG, we achieve all three aims at the same time and enable people to lead longer, healthier, and more meaningful lives. Healthier SG is not a government program or a financing scheme. It is a movement for Singaporeans, a new way of life, a new compact between people, your community, and the government. We may not have broken the iron triangle to open a straight and easy line to good health, but we have made a good start and carved our own path to achieve greater happiness and probably prosperity, depending on how you look at it, for ourselves, for our families, and our nation. Thank you, Chair.